So hi everybody, I'm just waiting for Dan, who's actually starting out our presentation. Thank you again for being here today. I see several folks in the audience that I might already call upon as we talk about, Dan's going to really do a system level look at healthcare issues. He's going to talk a bit about some of the, for example, the CMS 1115 waivers that have allowed people to restart Medicaid while 90 days left on their sentence, and talk about some other system level pieces. And I'm going to really talk about boots on the ground, what we've learned at the Hawai'i Health and Harm Reduction Center about working with people in reentry, particularly around their medical pieces. And then really great that we have some of our Medicaid fairies, I call them, that help people register. We have, I believe, the only health plan that has a reentry specialist here that we can hear a bit about, as well as the Department of Health and other colleagues if I need questions about CCS, AMHD, stuff like that, Steve. So we'll hopefully make this interactive and really hopefully again make it some practical tips of both the system level pieces and also again lessons learned. While we're waiting for Dan, I think I can share that the MedQuest division is working on their own 1115 waiver. I was just filling some time.
Oh, yes.
Their own 1115 waiver, and there's 5 things that my understanding DHS is looking at. One of them is using the California model for the 90 days to start Medicaid. Second is contingency management, which for those of you who are aware of that is actually a resource-based way to work with people around substance use. Another one would be stabilization sites that I'm sure Steve knows much about, which is for people that are struggling and coming out of respite. Native Hawaiian healing practices, to have those covered by Medicaid. And I'm blanking on the 5th one in a moment. So
I don't know. I learned from you. I have
contingency management,
anxiety.
stabilization, corrections, Native Hawaiian healing, and the other one will come to me by the time I talk.
So street medicine.
The street medicine is already covered now. Yeah. So anyway, we can talk more, but I want to turn it over to Dan, who's starting us off today on our systems. So I can do this slide, or do you want to do them?
I could reach behind it. Can this actually reach all the way over here?
No, because of the cord. Yeah.
Great. Well, everyone, thanks for having me. I've had the pleasure. We're not standing up. I don't know what to do. This is a small space. Is this okay for everyone?
Yeah.
Okay. There's no dance moves, so this is it. So my name is Dan Mishak, and I have had the pleasure of living in Hawaii for 4 years. I took a policy job and was fighting with the real estate world, rental market world in Hawaii, and so moved back to the continent in order to work on some of these policy issues that I have been working on for the last decade. So today what I was hoping to do for this conversation was just to do a little introduction to the work that I do, the nonprofit that I work at, what we're focusing on, and then, perfect. I knew I had the points there. What I'm hoping to do is to just kind of paint this picture of, a lot of the ways we talk about and think about people who are involved with the justice system. We heard it today from some of the earlier speakers, was about like individual moral failings and then overcoming those. The truth is that we actually criminalize people with some pretty critical health needs. And we also criminalize some pretty bad social factors, such as housing and houselessness. And those people end up inside of the jail. So what I'm trying to do is paint the picture a little bit of one of, rather than it being about individual moral failings, which then it's the responsibility of that individual to stop the cycle. We heard that today. Stop the cycle. We want to stop the cycle for families. There's no talking about stopping the cycle of the systems that we've created that keep on having this go over and over again. So I want to talk about this. How do we stop the cycle of the system? And so in order to do that, I wanted to talk about folks who are incarcerated, their unmet health needs, and then also talking about what does this look like at a system level? Like, there's reasons why our justice systems operate, especially when it comes to health, the way that they do. Some of those come from statutes that are from 1965. Those statutes are changing, and there's also new executive opportunities from the federal government that are changing that. This is what I ended up leaving the island, leaving Legal Aid Society to go and work on. And we've had, these are things that I was told never happened in my lifetime. And here we are now, and I'm saying, all right, now we're going into the implementation phase, which is going to be a disaster. But that's okay, right? Because we've already got a disaster on our hands. At least this disaster is one where we're trying to figure out how do we make a better system that works for some folks. So I want to talk about that, and then also to just paint a little bit of a picture of what can we do when we reframe some of these challenges through the healthcare lens. And frankly, what I think we can do is whatever we want. We really can create systems that work for people, that create real off-ramps out of the justice system, that stop stigmatizing and destroying people's lives. And so I'm just going to talk about that. So coaches, who are we? We're a nonprofit. We started in 2005 with a grant from the Robert Wood Johnson Foundation. I started working there after I wrote a paper. So I have an aunt who had schizophrenia and was bipolar. First responders, whenever she was in the midst of a crisis, was the sheriffs. That's not great. And her as a white woman who had a husband who had insurance had significantly different outcomes than my neighbors when I was living in the J.C. Napier community in Nashville, Tennessee, when I would see people who were exhibiting the exact same symptoms as my aunt, who would be I saw a woman thrown to the ground, police all around. She was naked because that was what my aunt would do whenever she was starting down that road. And just seeing significantly different ways in which the justice system responded to her versus how it responded to my aunt. So when I was in law school, I started realizing the systemic ways that we've structured all of this from the very beginning. Obviously systemic racism, and then also just the way that we built our healthcare systems so that people who get involved with the justice system get stuck in a shadow health system where they can't actually end up being able to get into the broader health system and have their needs met. At any time that they might not be progressing along the clinical expectations, that behavior gets criminalized and then they fall back into that shadow health system. So ended up walking down the street, meeting a nonprofit that was working on these issues and had worked with them since. So this is kind of our guiding thing right here. This is someone who's involved with the justice system, or just anybody, right? We all get health care from a lot of different providers. I go to dentists, I go to a Jungian therapist, which has been a lot of fun. All I get to do is talk about my dreams, so I don't have to annoy anybody in my family. It's a lot of fun. We go to clinics, we have people in nursing homes. But the thing is, we left out of this, and when we're doing kind of a patient-centered approach for how we serve people, we try and bring in all of those different places where people receive care, share information, share a plan for what's happening with somebody. But we leave out this place, the jail, where people who are usually black or brown, usually are poor, have some chronic health needs, end up finding themselves over and over again. So my goal has been, how do we actually treat the jail like a different healthcare provider with the same ideas of quality, transparency, and connectedness to other community systems? How do we actually build that? So, so this is what the nonprofit does. We're a part of the convening industrial complex, which is we bring people together from so many different silos in order to talk together. I actually find it very useful. We were just on Oahu doing the sequential intercept model there. And I'm now forcing Heather to go through my first draft of that, so the ball's in her court, which just feels like a great place to be for 15 minutes until you get it back. Just bring together people from health and safety places to start talking and realize, oh, we're serving the same people, and actually you could help us and we could help you, so how do we actually figure out how to do this better? We also work on policies, which is what we'll be talking about now. And then provide technical assistance to states, counties, and the federal government. So some of these policies here, I want you to know that the federal government was developing these policies. They asked me to be a stakeholder in it, and they were developing these policies while Kochis were going in the background. So this is kind of an exciting background for how this was developing. I'd get up at 3 in the morning to be a part of some of these stakeholder calls. And people are like, what is happening behind you? And I was like, they want to know if a fire alarm was going off. So I wanted to just I pulled these from the news. I should have done the date on that one. So this is just from August 8th. This is one from last year. And I just wanted to show from the very beginning that we have in the news right now these two articles from Civil Beat, and they're showing how healthcare systems and justice systems are how the needs overlap, right? So here we have an EPIC fail. EPIC is the name of the electronic health record that exists inside of the jail. We have not had a functioning electronic health record inside of our jail for who knows how long, because we only found out after the Civil Beat did this article. If you don't have a functioning electronic health record, how can you transfer the data of what you did for somebody while they're incarcerated out to community providers? If you don't have a functional electronic health record, how do you know what an individual is getting in the community before they come into an incarceration setting. So not having a functioning electronic health record means that people in the community receiving services, if they're arrested, they're taken to the jail, and then the jail has to try and figure out what the heck do we do with this person? Are they here because of a meth-induced psychosis? Have they not filled their prescription? What's exactly going on here? And it's not a great way to run a health system. It's not a great way to run a jail. And what it means is an actual burden falls on the jail to try and figure out all of what are we going to do with this person who has some pretty critical health needs. This other one on the other side, so sort of this electronic health record is like, how do we collect data from the community in order to inform our decision making while they're incarcerated? This we see people who are kept incarcerated. By the way, civil beat, if anybody's talking to them or anyone's there, stop saying things like inmate. I mean, it's like, this is not the 1980s or 90s here. Let's talk about people as people. So people who are incarcerated are people who are eligible for parole, are being kept in prisons until they die because they can't find a place to house them in the community. I mean, this is a systemic failure, but this is not who we are. Like, this is not who we want it to be. We don't want people who are eligible to be back in the community to die with their family and keep them from being able to do that. So this is another example of the lack of connections between the systems inside of jails with community systems. If we could actually figure out how to integrate these better, then we could have real off-ramps for people as they're leaving and be able to really start addressing this as a health problem and a health placement problem rather than what it is now, which is where are we going to put these bad people when they're out? These are people who have served their time and who deserve to be able to, frankly, just die with people around them who love them, and we are not doing that to them. So health and justice are intertwined deeply here. Jails are really frontline healthcare providers. Dr. Champion's here. He could talk so much more about what you called it an airport when we were doing the sequential nursing model. People coming and going. It's absolutely chaotic. It's like an emergency room on steroids. And so but these are really frontline health facilities. People come in. This is a lot of federal data. It shouldn't surprise any of you that it's really a challenge. Part of what happens when we have these disconnected silos and systems is that we don't get good data. We can't get a good picture of what's going on in people's lives. So this is a lot of federal data. The federal data is terrible, but it exists. So we're using that. But we have 10.7 million people are jailed every single year. Each of those jailing, each of the times someone's incarcerated can lead to a loss of their health insurance. It can lead to disruption in the services they're receiving in the community. And given what we're going to talk about, the fact that many people who are incarcerated have some pretty serious unmet mental health and physical health needs, this is incredibly disruptive to some people whose lives are already disrupted in general. But the thing is that jails, average length of stay is only 25 days. That number's actually bumped up. Sorry, the new BJS data says the number's 30 days. But frankly, the truth is that people who are incarcerated are only there for a short amount of time, but the impact of that can actually have huge impacts on whether or not somebody can go back to their job, whether or not they can go back to their provider or not. And every single week, about 55% of the jail population turns over. So these are places of incredible amount of transients, people moving in and out constantly. And it's no wonder that it can become really challenging to prioritize healthcare delivery in these types of facilities, even though many of the people who are there because of their unmet health needs. So there's got to be ways to try and figure out how do we weave these systems together, because we do it in emergency departments. We're able to triage and figure out what people's needs are. Jails are just places where we can do it. There's huge benefits. I mean, we can talk about that later, but there's huge benefits to both the justice system and health systems to have better integration. But one of the main things is that we're spending a lot of money on broken systems. We spend a lot of money figuring out what people need when they're incarcerated. We spend a lot of money trying to figure out what we do for people when they come back into the community. And we spend a lot of money just policing and re-arresting people over and over and over again. And these are not great ways to spend money, but what is it, symbolic political theory? Being tough on crime is, saying we're going to be tough on crime is a lot easier to say than we've got a major health crisis that's going on, and we have to do a lot of reckoning with what we've built, even though it's going to save money. But let's not forget, being fiscally smart and taking, being a good steward of public funds is also some excellent symbolic political theory as well. So these are just some stats from the Bureau of Justice Statistics to just demonstrate the fact that people who are incarcerated in jails and in prisons have very high rates of chronic conditions. They have a lot of unmet health needs. There are a lot of needs that are being met in jails, in prison. And they have higher rates of infectious diseases. But as you can see here, people who are incarcerated just have a very, very high disease burden, have a very, very high rate of need for while they're incarcerated. Though that here in Hawaii, the cost of that end up being borne by the state, 100%. In some jurisdictions, right, the county would bear the burden of the jail costs, but here that's all being borne here. The policies that I'm going to be talking about that are changing, that cost would actually be borne 90% by the federal government if we could manifest that. So besides the rates of infectious and chronic conditions, there are very high rates of high blood pressure. These are compared to the general population as well. This is part of the challenge with data, is it's hard to compare apples and oranges. So we've got apples, guavas, and liqueur here. But you can see if you're incarcerated, chances are you're going to have high blood pressure, tuberculosis. It's more likely if you had to take a bet on, okay, you've got to pick somebody who has a high infectious disease burden or a high chronic condition. You can pick somebody who's incarcerated, or you can pick someone in the community. You'd really be a terrible gambler if you pick somebody in the general population. You'd pick somebody who's incarcerated. Besides just like the physical health and infectious disease aspect of things, people who are incarcerated, unsurprisingly, have higher rates of mental health conditions. I mean, this is, and also just underlying all of this, if you don't have a mental health condition and you're arrested, you're going to have one by the time that you leave, right? And if you're put in solitary confinement, you're essentially being given a mental health crisis. And this is what we do to people. And we call it like justice, and we call it, we say that this is, supposed to make people better, but it's not. And does anybody know where solitary confinement came from? Okay, well, guess. Yeah.
Wasn't it like the Quakers?
It was the Quakers. All right, gold star. Yeah, the Quakers came up with the idea of solitary confinement. The goal was to make people penitent. Exactly, yeah. Big whoops. The thought was if people spent time alone, they would become right with God. Well, now we're using it because, this guy this guy's attacking this guy, so we'll take the guy who's being attacked and we'll put him in ADSEG for his safety. You come out of that, you could be in ADSEG for a long time. I mean, in Alameda County, I was talking to a captain there, and they had someone who was in ADSEG for 2 years. I mean, this is like, and it was because for his safety, is what they said. So, this is, anyway, these systems, the way that they're built right now, they warehouse people with some pretty critical needs, and they make those critical needs worse. And part of that, a major part of it, is because we like the idea of having jails and prisons to be places where we can hide all of this. I mean, I'm saying we because I'm taking ownership of it too, right? I'm a part of all of this. There is something about seeing the needs of people, not having the ways to be able to handle it, that we got to get that out of our sight. So what have we done historically? Well, we send them all to Australia. We send them to Georgia. I mean, Georgia was founded by people who were incarcerated. We send them to Rikers Island. So there are reasons why we get people out of our sight. And then what are we doing here? We send them to Arizona, where we don't have to see them. We don't have to think about the failures. We don't have to think about the fact that we have 48% of the people who are incarcerated are Kanaka Maoli. We don't have to see it. And so, anyway, sorry, I'm like preaching a little. This is jet lag. By the way, this is, I flew in last night. I got in at like 8:30. I'm leaving tonight at 9. So if I say anything that is too preachy or absurd, it's only jet lag.
We figured out he's actually in the air longer than he's on.
Yes.
Territory for the conference.
So one of the things that's really important is that a lot of people who are incarcerated actually not had their needs met in the community beforehand too. So fewer than 1 in 10 people who were arrested and tested positive for substance use have received any treatment in the community in the previous year. So obviously we've got some outreach issues, but this is just one of the major challenges. We can look at it 2 ways. One is we're not doing enough outreach in the community beforehand, right? Okay, that's a way to blame all of us in doing community services stuff. But we can also look at it as an opportunity too. Is that, again, people have some pretty critical needs. So if we can actually use jails as what's called in healthcare case finding, we have more opportunities to be able to do more interventions to support people. And I think that there's major danger sign of that. I'm more than happy to also talk about the risks of bringing healthcare into justice systems. There's a very real risk there. But what I always say is, yeah, well, I mean, things are pretty bad already, and we will have new fronts on the future battles, but I don't want us to keep the fronts where we are right now. But people who are leaving incarceration, so people entering have some pretty critical unmet needs. People leaving incarceration are 12 times more likely to die of all-cause mortality, 120 times more likely to die of an opioid overdose in 2 weeks afterwards. And they die from every single cause that exists under the sun. And 80% of people who are detained with a chronic medical condition have not received treatment in the community beforehand. So what is the picture I'm trying to paint? That our justice system is a receptacle for people who have not had their needs met in the community. And number one, let's focus on getting people's needs met in the community and being honest about what people need and actually saying, how do we do something about it? And if they do end up inside of these justice systems, how do we provide them with high quality, connected, transparent care, just like we would expect from every other health provider that we go to? We don't expect hospitals, we don't want hospitals to not be telling us what's going on with someone, with me if I'm going there. I want them to tell my primary care provider if I went in there with a heart attack. So how do we build that system where, okay, we don't want to have to use it, but if we use it, it's got to be high quality, it's got to be transparent.
Before we get to the MediQuest, could you just talk a bit about the community standard of care?
Yes.
Because I think it's a really important concept for people to understand of what the burden is upon facilities.
Yeah.
And that's a term I often hear is community standard of care. Would you mind just defining that a little bit?
Absolutely, yeah. So, so it may surprise you to know that there are 2 populations who are guaranteed to have health care in these United States of America. One is Native Americans on the continent, right, like Kanaka Maoli or Kainai. The other one is people who are incarcerated. So because of a case called Estelle v. Gamble, the Supreme Court said that people who are incarcerated, they don't have the ability to go and make their own health decisions, they can't go anywhere and do anything, so it would be cruel and unusual to withhold from them health care. The standard, though, that the Supreme Court created said that a jurisdiction can't be deliberately indifferent to the serious medical needs of someone who's incarcerated. So, in order to get your needs met so the Constitution of the United States expects a jurisdiction could get out of that by either being not deliberate. They could be, what's the opposite of not deliberate? So, accidentally, coincidentally indifferent. The medical need might not be serious. So different courts have used different ways of looking at this. So, someone who does not have terminal cancer might not. It hasn't. There's a case that was specifically about hepatitis for someone who's incarcerated, and they said that they were not required to have hepatitis C treatment until they were entering liver failure, right? Because it's not serious yet, right? So this is the constitutional floor. Like, this is where we are. So you have, they're guaranteed care, but it's down here. And then after that, I mean, it's really up to the jurisdiction to decide. So some states have passed their own ideas of what constitutes quality care, or there's accrediting bodies that help create policies and procedures that are supposed to be helpful. But ultimately, there really isn't the same standard and expectation that we place on community health providers when it comes to, and even healthcare plans, when it comes to what the expectations are for that level of care. So in the community, you have grievance rights. You have the ability to actually ask, if you're denied something by your plan, you can grieve your plan, you can jump through all these hoops. You don't really have, I mean, there's grievance systems inside of a jail, but they're not necessarily, they don't have the teeth that a grievance system that is backed by certain 14th Amendment supports are, like, or different kinds of ways in which we constitute and think about rights in sort of the consumer markets. So it's a vastly different standard of care between these places. Some jurisdictions, yeah, I don't know. I'm not going to try and paint an optimistic picture.
But I think I just helped understand like what the requirement is and how some of us can continue to ask, what is that standard? And like, for example, for Hep C treatment, like you're not supposed to wait till liver failure. It's supposed to be treated at any phase of disease. And so could that then change?
Right, exactly, yeah. So if you were in the community, absolutely, right? So in the jail though, it's like, well, like they could still get treatment or whatever, like at that point, right, of liver failure. So, it's really how do we start pushing. Like I said, all of this is borne by local dollars or state dollars, depending on your jurisdiction. So a lot of them, they're like, well, we're not going to invest in, I'm not going to buy Solvati for these people that we already may not consider to be fully human to begin with. Not to like be explicit about how a lot of places think about people, but absolutely they do. So we'll wait, and then we'll like let them get that treatment in the community, right? And so there's a lot of reasons why jurisdictions want to push that off. So now this is like where the nerdy policy stuff is coming in, and it's the role of Medicaid. So Medicaid here in Hawai'i is called MedQuest. Medicaid is created by the 1965 Social Security Act, and what it's supposed to do is it is supposed to provide health insurance to people who are eligible for it. So before the Affordable Care Act passed, really, frankly, a lot of people who were incarcerated just weren't eligible for Medicaid. So that meant a lot of people who, Hawaii expanded. I don't know. I don't want to go into Hawaii healthcare history because I don't remember exactly. But before the ACA, basically 90% of the people who were incarcerated did not have any health insurance at all. But since the Affordable Care Act passed and Medicaid expansion happened, all of those people are now eligible for Medicaid. Mostly it's because they make below 138% of the federal poverty line, which I think is, another picture of what our justice systems operate on, is people who are poor. So basically now, pre-ACA, there was no health insurance, there's no community, there's nothing to connect to, right? Because there's no like community system really that supported them. Since 2014, now everyone in the community has access to Medicaid. Whether or not they're getting services or doing any of that, right, we're still frankly pretty early into this new world of Medicaid. But now all those people could get treatment in the community, and they could get treatment when they were leaving, but there was still something that was hanging out on the outside that kept them from ever being able to get those Medicaid services that they were eligible for on the outside while they're incarcerated. And that is because of something called the inmate exclusion policy. And I just did, like a month ago or 2 months ago, did a talk in New York on the radio about the inmate exclusion, and they're like, you gotta stop saying inmate. And it's like, I would love to stop saying inmate. I agree 100%. But this is the language inside of, unsurprisingly, 1965. Right? So there were two populations that were carved out of being able to receive Medicaid services even though they'd be otherwise eligible. The first is people who are in institutions of mental disease, which is inpatient psychiatric or substance use facilities with more than 16 beds, and people who are inmates of a public institution. So you could qualify for Medicaid for any number of reasons, but once you were incarcerated or you needed to go into a rehab facility, you did not have access to Medicaid anymore. And the reason was, there were good reasons in the 1960s because of like the incredible amount of abuses that we were doing towards people when we're putting people inside of mental health facilities and then never seeing them ever again. We don't want the federal government to pay for that. When it came to the jail side of things, it was more like we don't want to pay for any of that. So this was created since 1965, and it was really to stop cost shifting to the federal government. And it's like unsurprisingly, our terrible health system in the United States, no offense, it fits, you know? I mean, it's like not out of character to have this exclusion. So what's happening now is that this is changing, right? So this inmate exclusion that said, okay, you could be receiving Medicaid treatment in the community, you could be seeing your provider, you could be showing up for substance use treatment every single week. The moment you're arrested and taken to jail, you lose your access to Medicaid. That means your provider in the community, even if they wanted to go through that volunteer class that Jamie has to go through in order to be able to go in, she would not be allowed to come in and provide those services and be reimbursed by Medicaid. So what has that meant? That meant we create a health system inside of the criminal justice system that is not connected to anything else, that doesn't have the same transparency requirements that Medicaid does. That's something I should have said. Medicaid also has utilization review, quality assurance. It has the grievance rights that I talked about. It has a whole body of jurisprudence of things that protect patients. None of that is available to you the second you set foot inside of a jail door. And so when you're leaving, okay, sure. People were like, let's get people connected to Medicaid the second that they leave the jail door. That still takes a long time. It can take over a month to get your pharmacy benefits started up. If you're someone who's incarcerated because you have had a mental health condition, your medications were changed, and you decompensated, and you were arrested and taken to jail, when you're released, what are you going to do in those 30 days while you're waiting for your pharmacy benefit? Are you even going to be able to see a provider in that amount of time? So this thing written in 1965 has stopped us from being able to bring into our broader health system what happens inside of our jails. Medicaid, in case you needed more, no, go for it, yeah. In case you needed more reason to think about if we brought Medicaid inside of jails and prisons, what would happen is we could actually create a system across both of them. All of these incentive dollars, too, that exist for Medicaid systems, like Medicaid providers to adopt electronic health records, like we saw at the very beginning, those would be available for jail health systems. You'd have to meet the Medicaid standard of care. We're no longer just here at the floor. There's higher standards of care. It gives the state opportunities to regulate and think about things inside of the jail in a new way. For a lot of jurisdictions across the country, this has been really exciting for states because it's hard to reach into and do regulatory work inside of jails. This is the way that states are looking at being able to do this. It really aligns the health standards too, of what we expect from community providers with the standards that exist inside of the jail. And also allows us to think about this, right? So if there was dollars, so just think about it as like dollars flowing. Okay, so not even to specific service, but think about what it would mean to have the dollars flowing in, and you said, well, what kind of system do we want to create? Well, I want one that provides not just support for the individual while they're incarcerated, but for the families. Behavioral health support services for the youth who have been a part of seeing their father arrested. That's a traumatic event. So how do we actually build into it really services across the board to support the family at that time of need? When we're thinking about the coordination and collaboration of when people are leaving, how do we bring in things like Hawaii's CIS benefit, the Community Integration Services or Support? Services benefit, so that we can actually start providing people with the on-ramp into housing on the other side before they're leaving. That actually could provide avenues out. So there's lots of different ways, and this is one of the great things. Medicaid is a state-federal partnership. Is that the? Yeah, let's go to the next one. So all of this, Medicaid is a state-federal partnership, which means that the state of Hawaii has an incredible amount of flexibility to be able to define what works well for them based on what their needs are. So Judy Moore Peterson, who's the current head of the MedQuest division, did some really interesting stuff when she was in Oregon, creating these sort of regional health systems in Oregon, right? So that was because it worked well for Oregon. It's what they needed. So they built systems around them. That sort of flexibility allows us to have a lot of control of saying, well, what really are our needs and our expectations around when people are incarcerated? How do we get them out? How do we get them healthy? How do we provide off-ramps for it? And it's just a huge opportunity to do it. They do it through something called the Medicaid 1115 process. So it's very nerdy, but it's a waiver authority that's inside of Section 1903, well, it's Section 1115. of the Social Security Act, and what it does is it allows for the states to waive certain parts of the Medicaid program. And one of the things that, as of January, states are allowed to do is to waive that inmate exclusion. So there's some bumpers on like what's allowed and what they're allowed to waive. Those things are that it can only be up to 90 days before someone's released. Who remembers what the average length of stay is in a jail? 30 days, that's right, yeah, that's right. Average length of stay is 90, so that's gonna be the vast majority of time while somebody's incarcerated. You can maintain access to Medicaid benefits.
So would that mean they wouldn't even suspend it?
Exactly.
You would, if they're anticipating to be less than 90 days, they
Yeah.
just continue with the, so you don't have to work with the forms
Yeah.
and the, okay.
So there's 2 states right now that have had their waiver approved. California's was approved in January. On June 30th, Washington's was approved. Both of them are in implementation phase right now. But the way in California that they're doing it, they're saying, okay, average length of stay is 25 days, so that just means that we're never gonna turn off anybody's Medicaid when they come in. So that, the goal is community providers who are incarcerated, they can move in and out, have the same providers on both sides. So, it's early, right? And this is like since 1965, we have had this system as it is. So there's gonna be a heck of a lot of bumps along the way. But I hope that you're gonna walk away from this being like, there's something like revolutionary happening right now, and it's happening in very nerdy and very boring ways. But it can be, if once people get a hold of stuff, the things that the nerds say can become really powerful. That's important. So the bumpers on it. Here's the things that have to be inside of every single waiver that's requested. You have to have case management, 30 days before release and after. You have to have 30 days of medication-assisted medications for people, bridge medications for when they leave, so that you walk out the door with medications in your hand.
Yes.
And you have to offer for whatever amount of time you request, up to 90 days, all 3 of the FDA-approved medication-assisted therapies for substance use disorder. So methadone, Suboxone, and naltrexone. So that's the minimum. Like that's the minimum thing that you have to ask for this. The maximum is you could ask for the entire package of Medicaid benefits if you wanted to. But this is done through a state Medicaid process, right? So right now, this is the MedQuest division is trying to figure out what are we going to do with this. 2 states have already been approved. 12 or 13 more states already have waivers pending before the federal government, and states are doing it different ways. So Kentucky, for example, is looking at it from the point of view of we're just going to do substance use and we're going to like figure it out through that. So people who have a diagnosed substance use disorder, we'll get them, they can maintain their Medicaid benefits the entire time, right? It's fine, it's a great place to start, right? And they're also extremely ravaged by the opioid epidemic, so it makes sense for them, right?
So do you see reallocating money that's currently going from the state for healthcare through the public service to then go to Medicaid dollars, so that there's...
This is what's even more exciting. So great, I love this, yeah. So right now we are spending tons of money on healthcare provision for people while they're incarcerated. That's gonna get shifted, 90% is gonna go to the federal government, is gonna be paying for that bill. What's gonna happen to that money that the state was paying, right? They don't, again, they still don't wanna just shift the costs to the federal government. Each state has to come up with a reinvestment plan for that 90%, which allows for creating diversion opportunities for expansion of care that isn't covered by Medicaid. So all of that money has to be reinvested. And so Dan Tsai is the administrator who wrote this guidance. I was a stakeholder for this. He went beyond what I expected and hoped for. Those reinvestment dollars are what I would say is one of the most significant flexes of the power of the federal government to drive change through fiscal policy. So nerdy talk there. But that has been exhibited since the Civil Rights Act, in my opinion. So it is an incredible way of being able to fundamentally change the structure of our justice system.
And mental health support and substance use and
Right.
community programs.
Exactly. All of that money could go to community systems for diversion, right? And I also think it's important to think about this when we're talking about what kind of jails are we going to build, right? Because the jails are old and awful and terrible and outdated, right? And so there's going to be new jails there. Are we going to be building jails that are thinking about infinite growth and like, oh, we're just going to keep on locking up more and more people? Or can we envision a future where the jails aren't going to be growing forever, but all of the jails are going to be a lot more porous with community providers, where there's a lot more interaction between the community and the jails themselves? That's a fundamentally different jail. You know, and you might ask yourself, like, well, where's the model for that? There isn't one, because this is the opportunity that's before us now, is to really, really envision and imagine a justice system that operates differently. And it's because some lines inside of the Social Security Act are being changed. They're also being changed in one other way too. There's a statutory change that is going to go into place January 1 of 2025, which says that Section 5121 and Section 5122 of the Consolidated Appropriations Act of 2023 that passed in December, that says that Medicaid juveniles 30 days before release have to be given access to the Medicaid benefit for juveniles called, so the big benefit is called EPSDT, Early Periodic Screening and Diagnosis and Treatment. You have to maintain access to the screening piece of it and the diagnosis piece 30 days before release. And you also have to offer case management 30 days before and after release. So that's a statutory change. This is not something the state has the option of not doing. It's something that has to happen.
And the age for that is 24?
So this is the thing. So this is, like many people think it's, our initial response is this is the juvenile justice system. It is not. It is the adult system. There are a significant number of Medicaid juveniles inside
because of like foster and
so right. So I think Hawaii's age, I don't know if anyone else here knows Medicaid eligibility better, I think is 21 for
that's what her, she's an expert in Medicaid eligibility.
They age out at 19.
19, okay. And then if they're foster youth and age out, they can maintain till 24?
Yes.
So, I mean, already start thinking about what are the systems that are gonna have to change. Jails are gonna have to identify whether or not someone is a Medicaid juvenile in the adult system, and also whether or not they're a foster youth in the adult system who's aged out into MedQuest. You know, these are things that a lot of states are not thinking about yet because it just passed in December, and it's, you know, it's taking the health world and the corrections world, which don't really talk that much, like health as in like Medicaid bureaucracy world and the justice world, who don't really talk that much, and now saying, well, you got to do it, and these people have access to rights now. It's actually a violation of Matthews v. Eldridge if you don't give them the rights that they're supposed to have. This is a significant change. January 1, 2025. Yes.
Isn't the inherent conflict the social control policies of jails and prisons as opposed to medical treatment?
So what I hear you saying is isn't there a significant tension between some of the philosophies of incarceration and healthcare systems?
Who's worthy?
Yes.
It's been a problem.
Right, I think that there's a lot of questions about what this is going to look like when it's rolled out. So I'm a two-time graduate school dropout, so I have just kind of, so the first time I dropped out was because I was tired of killing fish and looking at their DNA. The second time I dropped out was because I was working on this stuff, and I realized I could move it instead of studying it. So the initial thing that I was thinking about was, how do I study as things like the ACA unrolls, and jails start saying we're going to shift from mail and trail to jail and all that, the ways that we do stuff inside of jails, to like now we're going to enroll you in Medicaid and start thinking about you from a needs base rather than the deficiency base. And what is that going to actually do to change the culture? Still an open question.
It'd be amazing.
If anybody wants to fund a PhD dissertation, I'm happy to do it. So yeah. So there's a huge, like, I just want to go through, I'm like sucking up all of your time. So these are, I only had a few slides, but I could talk forever about nothing. So these are huge things that are going to happen, right? So these listeners, hopefully we'll be able to share these slides with everyone.
What's my understanding is that going home is part of
But I think it just aligns so much more with what our values are, to actually say, how do we actually care and understand what people's needs are, rather than how do we get them out of our sight. And this is the way that we can really start seeing, not just seeing them, but seeing who we are in this process too, and to change ourselves along with this. So I'm excited for this, as you guys can tell, but that's all. So there's a question.
Yeah, I wanted to see if anybody had questions before we move on.
So I've heard you say a lot about the
federal cost shift. For people who are coming out of incarceration and then they stay out of incarceration, does it at some point shift to the regular FMAP?
No, yeah, it's still the same FMAP, yeah. So, so for the expansion population.
The regular FMAP is 50-60, 50-40.
Here, well, so for the expansion Medicaid population, it's 90-10. And these are all expansion folks for the most part. Right, so like for the normal like aged, blind, disabled, like that Medicaid, that FMAP is much, much lower. So, but when the Medicaid expansion happened, the carrot to get people to expand it was the enhanced FMAP. And actually at the like federal level, one of the things we've been fighting a lot is that every time we try and do some tweaks with this, a certain party is like, well, if you're going to do that, then you have to like, take the FMAP down. It's like, well, that's not going to be very. FMAP is that shared percentage. So for most states, for the non-expansion populations, it's about 50-50. For some of the poorer states, it can go up higher. I think Alabama's is the highest, but I can't remember offhand. But for expansion populations, it's 90% to the feds and 10% to the state.
And then one more question, are you seeing, how are the insurance plans that service Medicaid populations reacting to this new policy?
So, that's an excellent question, right? Michelle, how are you? Like that. So this is the hard thing, right? And I think this is one of the major challenges for Hawaii is everyone's inside of managed care, right? So the plans are going to be a huge part of this. Right now, a lot of plans are very excited about it because these are their members on the outside that they're not necessarily able to serve. The challenge is going to be administration of services inside, right? And credentialing, actually, credentialing the providers on the inside, major, major question mark. There is, I'm being recorded. There's exciting things happening on the federal level when it comes to like who's going to be the provider in carceral settings, and I'm happy to talk about that offline because I'm not supposed to talk about it. But I mean, I will never tell you my secrets.
Let's hope it's peer specialists, though, that peer specialists are able to work within the facilities, because that's, and be able to get the same kind of reimbursement you can get from peer specialists elsewhere, because that's, there's such a great model of peer support within incarcerated settings.
But Heather, are those peer specialists currently Medicaid certified?
No, you have to go through my understanding, and I'm looking at Stephen, I'm not to put the spot on you because I know this is, AMHG currently does a certification project that is supposed to be able to make that, if you go through that, first you have the certified peer specialist, if you have a mental health diagnosis, and once you pass that, you can take the forensic peer specialist, and that is supposed to be reimbursable. We just did our first one, and I haven't seen our first coding to see if we do get reimbursed. But I don't know, Stephen, sorry to put you on the spot if that's my understanding. Is that your understanding from AMHG?
It's my understanding. I mean, AMHG typically has never billed for peer specialist services, although our peer specialists are all certified, but we don't bill.
Right,
They're all
okay.
these non-billable codes.
Yeah.
Does that require us to do anything, apply for anything to get peer specialist Medicaid eligible, certified?
I think that's a great
They have
question.
to be
That would
enrolled.
do you have any sense of, they have a contract to do eligibility and sign people up to Medicaid. That's why I'm looking at my Kumukaki Health and Wellness colleagues over here. But we can, is anybody here from DHS, MedQuest? We can take that back to ask, because they've been actively meeting with folks around. By the way, I remember the fifth one, it's actually tenancy support, rental support.
Oh.
That's the fifth one that MedQuest is looking at. So again, they're looking at Native Hawaiian healing, contingency management for substance use, stabilization, or medical respite, the incarceration one, and then the other one is what? Mental, yes, yes. So, all right. Well, thank you so much, Dan.
Yeah.
I think we'll have some time at the end to see. Can we just? It's my Okole, so I was going to stand up. Anybody else want to stand up with me? Get your Okole moving.
Oh, there was one more question
Okay.
somewhere?
So just a real simple one. What you mentioned ACA. What was the legislation that made this colossal shift?
So, the Support Act in 2018 actually mandated that that CMS, the Center for Medicare Services, release guidance about what it would look like to provide services 30 days before release. The Trump administration didn't do anything during that time, but then when the Biden administration came in, they finally decided to actually do the stakeholder engagement and actually figure out what it meant. This is what took me away from Hawaii. So the Support Act is what created the executive branch side of this, and then the statutory change, though, that came through the Consolidated Appropriations Act, which passed in December. So it's the omnibus spending bill is also what it's known as colloquially. So that was the big change.
The waiver only applies to inmates that are Medicaid eligible, what about Medicare eligible?
Yeah, that's a huge question. I mean, huge problem. Yeah, I mean, it doesn't apply. I mean,
Medicaid only, right?
and that's the huge, there's an exclusion also on the Medicare side. So since most of my work had been focusing on jails, that's actually, very few of them are Medicare eligible. And so that's why my paper in undergrad and law school was about the Medicaid inmate exclusion. The Medicare side of things, a lot trickier and it's a lot harder, but I also think there could be more political will around it because so many people are aging
I
out.
was gonna say, we're aging, the Medi population is just gonna continue to
Yeah.
grow, for both, yeah.
Problem still.
Well, I'm gonna try to talk, or I'm not gonna try to, I am gonna talk about some lessons learned from the Hawai'i Health and Harm Reduction Center, and I'm not gonna make you memorize our mission statement, but if you remember the top part, reducing harm, promoting health, creating wellness, and fighting stigma in Hawaii and the Pacific. We are statewide, though our footprint on the neighbor islands is relatively small. I have one staff in East Hawaii, and then we subcontract with Kumukaki Health and Wellness on the west side, and then have staff on one on Maui and one on Kauai. We work at the intersection of the criminal legal system, chronic disease like HIV, so we have about 700 people living with HIV, mental health, substance use, and houselessness. We also run the statewide syringe exchange program and are one of the primary houseless and homeless programs on Oahu. So about a third of our programs are on the street, and I think that does lead into why we are such a natural stop for our health clinic is not primary care, we're episodic care, substance use care, sexual health, and wound care. But as you can imagine from the stuff that Dan just talked about, that unfortunately it leads a lot to people that have the experience of being incarcerated. And we have a medical mobile unit on Oahu, and on the neighbor islands, we predominantly work on overdose and substance use related issues. So just since harm reduction is in the name, I just want to be really, I'm an unabashed harm reductionist. I'm happy to say that. There's no one definition, but we define it as a non-judgmental approach to public health that meets people where they are, celebrates any positive change with the goal of minimizing harms of actions that pose adverse and social and health outcomes. That's a fancy way of saying that we try to meet people where they are, meet basic needs. Some of the theories that harm reduction is based on is everything from Maslow's hierarchy of needs, and if you don't have a place to sleep or food to eat, how are you ever going to address connection or substance use issues until you have basic needs met. We do a lot around what I call people's willingness, readiness, or ability to change, and again, meeting them where they are, both literally on the streets and then figuratively in their readiness to change. We are really working to be a trauma responsive agency. I'm really grateful that I'm part of the Trauma Informed Task Force and the Office of Wellness and Resilience, which, by the way, just shout out to Tia Hartstock. If you don't know, she has been kicking it as a brand new Office of Wellness and Resilience responding to Maui, getting 1,000 behavioral health providers together, just doing amazing work to try to mitigate the trauma of what's happening on Maui. So she would be here if she wasn't probably on Maui doing the work that she's doing. And then, like many of you, we use motivational interviewing and other evidence-based practices. But the biggest piece is, as long as you aren't posing harm to others, you are welcome. The only people that are ever, I hate the word banned, but are not allowed in our program, it's usually for a short amount of time and only if they have had a violent episode. Otherwise, we really try to work through discomfort. Because discomfort and safety are different. I see a lot of folks who say people are service resistant. I think services are people resistant, personally. And so really trying to say that, where do we need to do our work differently instead of why do you need to change to fit into our system or our services. Yeah. So I'm gonna talk a bit about what we've been doing prior to incarceration when we know it. We don't always, but sometimes if people are released on their own recognizance or are able to meet bail, we know that they're going to be going to court and there's a chance they're going to be going inside. So there are things we can do. Oftentimes, most of our folks are just gone. In fact, we had one Monday, where'd she go? And then Tuesday, found out she was at cell block. And so how many of you have had somebody where you're working with them in mental health or housing or something and then they're just gone into the void, right? And then all of a sudden they're back, oftentimes in worse shape, unfortunately, whether it's mental health or physical health or even worse, HIV. Or worse for me, we had a housing voucher for them and couldn't find them, and then that housing voucher went to somebody else, which happens more commonly. So these are what I'm going to focus on. So some of the ways that we have found is thank you so much to our, again, Kumakahi, and we're blessed to have a subcontract. We have two health navigation specialists. So the first thing we do is make sure that you already have MedQuest if you qualify. Because if you have it and they have your updated information, it's gonna be easier once it's suspended to restart it, and we'll talk a little bit about that. The other one too is really, can we not only find out what are the active health needs are, but can we, and I'll talk a bit about this morning, can we have a PHI or a release of protected health information so that we know what are the health issues? This is, I'm guessing, a little bit about what you're talking about do we really want that full transparency, because we don't want more stigma for folks that might have mental health or substance use, but yet we need to know what's going on. So I'm incredibly lucky on Oahu that my medical director, Dr. Wang, also is providing medical care over at the cell block. So we have a unique opportunity that most folks don't have, that we can interface if somebody's in cell block. And I just want to thank Department of Health, because the Department of Health, actually Adult Mental Health Division, was like, there's nobody really providing health screenings, and AMHD pays for, on Oahu, screenings for mental health to try to support jail diversion, other aspects, but it also just puts nurses in. What happens here at the cell block for when folks are picked up before they are either released or go to HCCC? Is there nursing support? Anybody know?
I can talk about it from 4 years ago.
Not self-block, not that I know.
Okay.
We do jail diversion screening, but I don't
Okay.
know.
So ideally, getting nurses who can actually prescribe medications, do some basic self-assessments, can sometimes get the medications there at the cell block before they go either back into community or into the correctional facility. So I'm just really lucky that I happen to have that connection. It's not true for most folks.
You get cup noodles every day.
What?
Cup noodles.
Yep.
No nursing.
So, if folks are, I'm also the chair of the Continuum of Care on Oahu Partners in Care, so I'm gonna talk a little bit about the intersection, because one thing that I believe, somebody alluded to this, I think it might have been Ian, and forgive me, I'm forgetting at this point, but once you're incarcerated for 90 days, or in any system, you lose your chronic homelessness status. That's a definition that HUD gives us, and why that matters is most housing resources are linked to having to be chronically homeless. So this irony is, you could be homeless for 10 years, get incarcerated for 91 days, come out, you are no longer considered chronically homeless according to the federal government, which means that you're no longer eligible for the majority of the subsidies or housing vouchers, unless you aren't. That's just as simple as that. So one thing we're trying to work on is, for example, the Department of Education has a much better understanding of chronic homelessness. They include youth that are couch surfing, or youth that are, staying with relatives, things like that, because you need to be able to house people, and if the resources are limited to this jurisdiction, or this limitation. And then I'm a big believer, and I'm stoked that Michelle's here from one of our health plans. I'm gonna put her on the spot in a minute, because unbeknownst to her, I put her name in my PowerPoint. Because if we can, so if I'm already working with somebody, or my agency is, we already hopefully know, do they have United, do they have Kaiser, do they have HMSA, and do they have a health coordinator there? That, again, if we know they're going in, we could even talk about that so that we have a case conferencing with either the health coordinator at the plan. For folks that have severe mental illness, I think that either AMHD can provide mental health support, or until they can get what's called approval of 1157, which is another form, a MedQuest form that you can fill out if people have severe mental illness. And then it gets approved. They have what's called community care services, which is an extra case manager for mental health. So all of these folks that are supposed to be part of the care team, wouldn't that be cool if before someone's incarcerated, we're like on the same page, knowing what's going on, and even better if we can then communicate that inside. But even if not, at least to catch the person on the way back saying, hey, we are all talking and we're all part of your care team. I know this is easier said than done, but these services are in existence, and it's just making sure that we connect the dots between who the healthcare provider is, and if they have high utilization, right, of whether it's hospital or other, chances are they have a healthcare coordinator, and they may also have a housing coordinator if they're houseless, and they may also have a behavioral health coordinator. So you can actually have 3, I believe, health plan coordinators that are part of your case, and oftentimes if we don't bring them together with the rest of the care team, we're losing that kind of leverage point.
And just thinking about a judge, we don't have any judges here, right? But what it would mean for someone to appear at arraignment with their case manager saying,
It makes such a difference.
Yeah.
My case managers go to court, and I can't, it makes such a difference.
Yeah, I write letters
yeah.
of support,
Yeah.
everything,
Yeah, so we might even be able to prevent the incarceration
Exactly.
by going, especially if it's like a probation violation or something like that, it have to do with a relapse or something that we can talk about how it actually caused more harm. We went to one and said, if this happens, they're gonna lose their housing and they're gonna lose their job. And they now have a job in housing, and you putting, you know, and then they did not go back in. So that would be ideal, yeah. And I think that's part of, for those of you familiar with law enforcement assisted diversion program that we and others on the continent have, that's part of it, where you actually would bring together the prosecutor, the public defender, the case manager, and the person, and if they hit law enforcement again, you make a decision about, well, does it make more sense to not put them back into the system because they're having this progress, or really, is there a real concern in that really going inside for whatever reason might be best for that person or for. So I think that folks know that VineLink is really made for victims of crimes, but we use it all the time to sign up for our people to know when they're released. So by putting somebody's name into this, you can get texts about if they're, you know, where are they in the system, if they get released. So that's one of the ways, as long as you know that it's happening and you have a release for their information, their date of birth, you can be able to follow this, and it's a really amazing way to, since we often don't know when somebody gets released, to go, okay, someone's got released, let's go try to find them either at OCCC or HCCC or wherever.
And this is, I'm sorry to jump in, this is awesome, this is like such a good fix, and this is sort of, we could do something like this if we had health information exchange and electronic health records that could say.
It actually give you an alert.
Exactly.
Yeah.
Go and Dr. May can log in the morning and say, oh, you know.
There's my patient, yeah.
Yep, they're in, yeah, so
Yeah.
it's be really useful tools.
Yeah, no, and because it's very similar with the emergency room too, where I'm really lucky that our medical director has privileges at most hospitals, the same thing, where they go, oh, look, they're at Queens, oh, they're at Straub, because again, we can wrap around them whenever they're in these other systems, because they're gonna be coming back out, as you mentioned. So a lot of it is really counseling our folks and saying, the more that you can, we want you, your information is yours, you can decide who wants it, but if you sign these PHIs, so this is something that we just started, and we're waiting to see that if we sign a PHI on the outside that's ours and they take it with them, would that allow any conversation between my case managers and my counselors and my nurses with somebody while they're inside? It really depends on whether or not there's a champion. So we have a few of the healthcare providers in the public safety system that will reach out to us when our folks hit them, particularly if they have HIV or hepatitis, because that's part of what we do. And then the biggest one, please, big copies of all their IDs, right, all their documents. Some people have even trusted us to hold them. I don't think that everybody wants to do that, but some of them have, because there could be a challenge with getting those back. And I think you heard about Director Johnson mentioning the ID program, where they have my understanding is that they're working with the Department of Motor Vehicles, that they would process the ID at the facility, and then DMV would like mail them to them. Is that?
They would, yeah, DMV would actually.
Right, because if there's one person who knows who somebody is, it's somebody in incarcerated, right? Like, I can't always prove who somebody is if they have no documents, but I'm really hoping that most people that are incarcerated are validated to who they are. So that we can actually get these documents, and so because that's the number one barrier to housing, is having, as you probably know, documents for that.
See, and then like that's an issue that I come across when I'm having people get identification. Where are they going to have it sent to?
Right.
They're shelter homeless or something.
Right.
Where do we have it sent?
Right, so could we either send it to, I don't know whether it sounds like they're working on a way to get it sent to within public safety,
Case management.
or to case management, like we get tons of folks of mail and we keep it while they're incarcerated, but again, it takes that coordination to get that ahead of time. Anybody have any other tricks on prior to incarceration than what I mentioned? I talked about kind of getting all your paperwork aligned. You can, by the way, the Medicaid, there's the 1179A form suspends, and my understanding is they do it automatically once someone's incarcerated. And I'm sorry I keep looking at you, Rochelle, but that's my understanding.
No, that's fine. Whenever they go in, if they had MedQuest, they suspend their case. And then if they have the letter from their social worker, when they're coming out, that gives the date that they're gonna be released, then we call the outreach department, and they do the research to see if they were on MedQuest prior to, and if they were on, we can reactivate it with
With
that
the same form, and then
Yes.
under, my understanding is on the back side, it says reason you would put incarceration. But if you can prove the date of release, they can expedite that.
Yes.
So again, what would be wonderful is if they can stop or suspend Medicaid on the intake, why can't they reactivate it on the way out the door? So that we don't even have to have an outside social worker or whatever, that the same mechanism that suspended it when they came in would reactivate it when they leave public safety's jurisdiction or whatever.
Because, and also, like what I said about the pharmacy card, you can start the benefits, but the pharmacy benefits still might take longer to get
Right,
started.
right.
So,
Well, there's certain ways that we can try to expedite things if we know, if they contact us at the moment, like with Going Home Hawai'i, when they had that, you guys halfway house, they call right away, and as soon as they get there, we research it, and usually by the next day, within 24 to 48 hours, we'd have an answer.
So on Hawaii Island, these are your best friends that are gonna get folks reconnected, either enrolled in MedQuest if they aren't already, or then if it's been incarcerated, restart the services and can do it really quickly. So really appreciate Kokua Services for all that you do to help our community access the benefits that they deserve.
That's awesome.
So why, so what about inside? So I've heard the term in-reach, so I'm starting to use that, which is where us in the community in-reach into the facilities. So you do need to go through a training program. You heard Dr. Miller talk about it this morning. I've been through it as well. I will admit, I actually was traumatized going through the volunteer orientation, just because anyway, and I understand that they want to ensure, I mean, I don't understand that I'm traumatized, but I understand they're trying to limit, people getting messages in and out and making sure that you aren't manipulated into doing something that you don't want to do, but they basically make it as like you can't even say hi, because if you say hi, it means this thing, so I'm hoping that we can get maybe a more trauma responsive volunteer program, but there is quite a lot. You have to get consent to search, you have to do a criminal history check, so if you have a history of incarceration and want to do peer work, it's going to be particularly hard, and I'm hoping with forensic peer specialists we might see a change, because I think we want peers to be going in and doing this work, and yet right now they really aren't allowed to because they're seen as a risk from the public safety side. I don't know enough about those pieces other than it's a lot to go through, and it's a multi-day course that you need to do in addition to all of these. But once you do this, then you can. So my agency goes in. We do the clear backpacks. It's so much easier to go in where they're not looking through all your stuff. So we have clear backpacks. So they know exactly what we're bringing in. We make sure that we're make good relationships as much as we can with the staffing there. We understand that if they have low staffing, if there's been an incident, they may not allow us to come in because they're worried about safety or about so trying to just be really flexible. But the more that you have a relationship, the more likely you are to get the call that they're on lockdown before you actually drive over to the facility, right? Or that they don't have enough staff. So I really encourage for those of you going into facility or wanting to really build those relationships, because what we find is that it's a win-win. We're providing services in reach that help the staff there. And the more that they can help us by notifying us if it's not good, or there was just a COVID outbreak at Women's, so my staff decided that's probably not the best time for him to go in, things like that. And then the other great thing is that you can do in-reach. So we do HIV and hepatitis, and now we're doing buprenorphine and treatment for opioid use disorder. Then they're more likely to come find us when they get on the outside. So I heard Director Johnson talk about in-reach being a big priority, so let's see what we can do in the community to get more into facilities to create the transition out. As I mentioned, we are building some relationships with some of the healthcare providers inside. It takes a very special person to do, again, they don't get paid that well, they have really intense working conditions, and there's a lot of unmet needs. So be really kind to those folks, because they're doing really hard work, and oftentimes not at the pay they would get if they were working in private practice. And now my understanding is almost every health unit has telehealth capacity. So something else could be doing is people could potentially have an appointment with somebody outside. Like for us, if the appointment can become funded by a grant, I don't need them to have Medicaid, and then we can do the telehealth with the person going to the unit. But I also just wanted to turn over to Michelle for a moment, because she's the only person I know of within a health plan that's focusing on reentry. And I just thought you could share a little bit about what you're doing to help facilitate services for United members around incarceration.
Sure. Hi everybody, my name is Michelle Fay, and I'm the Justice Liaison at United Healthcare. So my job is basically to work with all of our justice involved members, and my work initially started off as helping people who are coming out of jail and prison within their first 6 months of release to make sure that they're set up with care coordination, right? So if you have United Healthcare as your Medicaid plan, if you've come out of jail or prison within the last 6 months, then you're automatically entitled to care coordination, right? So that includes making sure that you have a PCP appointment within your first week of release, pharmacy benefits, turned on as soon as possible. And I work with the care coordinators then to make sure that, for example, if somebody has a continuing case, that they are aware of what's going on, right? That they continue to be able to navigate both the justice system, or what I prefer to call the criminal legal system, because I don't think there's much justice in the system, but both the criminal legal system and the health systems. My work has also then now expanded to just consult with anybody within United Healthcare who has who we suspect might have had any justice involvement at all in the past. So that can include, for example, I worked with somebody who had a sex offense from North Carolina, and then we were able to figure out that, actually, or was it South Carolina? But anyway, that we figured out that they're, because of their sex offender status, they were ineligible for all the housing programs, right? But they just happened to be from a state where that law was found unconstitutional, and so now we're actually working on removing their sex offender status in order to have them eligible for housing, right? So sometimes we get, cases like that, but also a big part of my job now is just keeping on top of people's criminal legal cases, right? Because a lot of our members obviously are dealing with behavioral health issues, they're dealing with houselessness. Keeping track of court dates is really difficult, right? And so lots of times, as I'm sure most of you have seen, they often just miss their court dates, and then a bench warrant is put out on them, and then they're susceptible to getting arrested at any time. And so I work with both our health coordination side, which is our social worker or nurse health coordinators, and our community health workers, and also on our behavioral health side for our field care advocates, and we have a peer support specialist to help them keep track of their cases and to also advocate with people involved in their case. So whether that's the defense attorney to know that, for example, they have a housing voucher available to them, right? Or to let probation and parole know that, we're on top of working with our members to try to make sure that they don't recidivate. Those are some of the key pieces that we do. And I do use VineLink a lot because that helps me stay on top of when people might be getting out of jail or prison, and so then I work to make sure that their Medicaid reactivation is expedited, and so we are able to expedite their Medicaid reactivation in usually less than 12 hours or so, and so we hope to kind of decrease that gap, right, during which people do not have any Medicaid coverage when they come out. But I think this is why the 1115 waiver is so exciting, right? It gives us a whole new avenue. It's almost like we're creating a new wild, wild west where we get to make it where we want it to be, and I think that will really transform the landscape of helping people as they're coming out.
So I listed as you heard before from Rochelle and then now Michelle, that if the person already had Medicaid, they're going to suspend on the form, and then you want to reactivate that. And then I also put up there the DHS form 1149 that can be filled out by a provider to expedite. And the reason I put the fax number down is the fax number is not on the form, so it's actually really helpful to have that. And that could be, so that's what our medical director would put in if they aren't seeing the benefits activate, to be like, here's an urgent issue with their mental health or with their physical health or whatever. That is why they need to get this activated ASAP. And then as Michelle said, whether it's United or any, again, most folks should have a health coordinator. Again, if that folks have mental health challenges, they should have either an AMHD case manager, call it CBCM, a community-based case manager, or ideally we'd eventually get them qualified for the health plan that all goes through Ohana. So even if they have United for their Medicaid, they would still have Ohana for their CCS, because it's just how the decision was made. And then, sorry for all these acronyms, now there's CIS, which is Community Integration Services, which is a newer, this was the last waiver that MedQuest got, and this is allowing, HCRC does this, where it's allowing some pre-tenancy and tenancy support for people that are houseless, because it is seeing the impact of being houseless on healthcare, and so each person, one person can enroll in CIS, and then it allows more intensive case management and some more support around housing. So people could have quite a few plan-based or plan-supported case managers or coordinators. As long as we're on the same page, it's awesome. As you can imagine, it's also crazy making if
Right.
all 5 are not talking or saying something different to the person, and they're like, what, this person told me this, but now you told me this. So that's why I'm a big believer in case conferencing and team care
At
coordination.
probation and, or drug court and all of that too.
Right, yeah, no kidding. Yeah, probation officer, that's actually really good, yeah. So, the other big piece, we see a lot of folks coming out, especially because we have a mental health, I have an addiction psychiatrist, a couple APRNs, we see a lot of substance use and mental health folks, folks that struggle with mental health that come out without any medications, and may be really vulnerable, and there is no triage. So ideally, it'd be nice to have a reentry center that had a medical component. Because there's not, we have the hospitals and urgent care. There's no other real options for folks, especially if their insurance is not activated yet. But being mindful that for some people, an intervention in a psychotic break within 24 hours could make a huge difference. And so getting people to getting care to see if we can get them this higher level of care if necessary to prevent a worse outcome. The other piece too is just to note that if somebody is in the hospital, there are more pathways to other housing. So there's medical respite homes that people can go to from the hospital. Right now, you know, there's a medical respite called Hawai'i, at least on Oahu, right across the street from Queens. Through the CARES line, which is the 988, the Department of Health, AMHD, funds a lot of stabilization sites for people with mental health challenges, and so they may be able to go straight into that piece. And then I will put Dr. Champion on the hot seat, but eventually we may have a center in Ivole that also is going to be potentially be a place for folks, right? That hopefully would help address any mental health concerns if they're in crisis. And I'm assuming that justice involved folks are a big part of the community that you're thinking about, of folks coming out that might be struggling mental health wise. Yeah, please.
So it was already mentioned earlier today about a crisis hub or crisis center or drop-off center, a best practice that's been being stood up all across the country. So we're working on one now in urban Honolulu. Usually this is a place where law enforcement can hand off somebody who's in crisis instead of going to an emergency department. One component kind of replicates the emergency department, a behavioral health emergency department. And then you can, depending upon how you build it, and I'm saying this because we all have got to creatively think about what this looks like in our communities, because we're going to be doing it in every county in some form. You can spackle things onto it, crisis stabilization beds, transitional housing, other wraparound services, use of peers, etc. So the one in Ivole is going to be for law enforcement transport starting off. We'll have 8 crisis stabilization beds, and there is housing associated with it as well. So, but I do want to say it's a good model to learn about, and we've got to think about it together. What's the best fit for the community? We're starting in Oahu, in urban Honolulu, but we'll also need something on the windward side, maybe on the west side of Oahu, you know, here on the Big Island, east, west, middle. Yeah, thank you.
No, I really appreciate that, Mr. Champion, and I have to say, our Chief Justice has been a big proponent of this. Several of us were at his fall 2019 summit on basically understanding that our jails and our prisons are our de facto mental health system, and that's not okay. Brought in folks from Miami, brought in folks from Arizona, really put a commitment to doing this, and COVID happened. And now it's picking back up again, though, that folks just went to Miami to look at this model where they did build a new facility that was more about wellness, mental health, and less about, you know, the bars, and then really learning from the Arizona model, I believe we were looking at for this drop-off. So there's a lot, it's really interesting to see from the top down that whether it's been CJ or others just really bringing this together, and I need to keep going because we have to end. So cell phones, I won't get into this a lot, but I got blessed to have an anonymous donor who donated $30,000 during COVID, and we were having the release of folks from incarceration. We did a pilot project. We need to get cell phones out to folks. How do you make appointments? How do you stay probation? How do you get back to your health care? How do you do telehealth? You have to have a phone. And we, because it's a coconut wireless, so these are folks without phones. We were inundated and gave out over 300 cell phones in 6 weeks. And the only thing was you had to have been incarcerated in the last year, and it was just showed you what a need it was. I am allowing this funder to see if we could do more, but we had so much progress, and then it was amazing to me how much just folks were grateful to just have connection, especially because these were smartphones, so they could do all of the things that they needed to do. I just want to highlight that please get naloxone if you don't have it already. Really appreciate this. In fact, I probably have some on me somewhere. But people, as you saw, 120 times more likely to die of an overdose after incarceration. Happy to share that 5, again, naloxone vending machines are coming to this island. And thanks to Dr. Gavin Takanaka, who I want to give some props to. He's behind the scenes in health. He's getting a naloxone vending machine in all 6 major facilities. So Halava, all 4 correctional facilities, and then and women's. So just really excited that we'll have naloxone for people that are leaving to be able to hopefully save their lives. And then again, just have to plug the 988 because people, mental health might be up, post-traumatic stress is real. And then as Dan mentioned, folks, unfortunately, we have seen transmission in Hawai'i facilities. Now, the data's old now, 20 years ago. But 20 years ago, they were testing for hepatitis when they came in, and they were negative, and then they were testing hep C when they left, and there was some hep C tattooing, sharing of, all of those kind of pieces. So just it's a lot less, but being mindful that there still is infectious disease transmissions happening within the facilities. I already mentioned this, so again, trying to really work on HUD to get rid of this so that our folks that are in this also is for treatment. If you went to treatment for 90 days, you would lose your chronic homelessness status. And just want to note that our providers do telehealth. In fact, I'm really grateful for Dr. Hannah. We provide, if you don't mind me sharing, Dr. Hannah, some buprenorphine telehealth support for some of the folks at BISAC. As Hawaii Island continues to build its own buprenorphine providers, but we are willing to see, we do some tele-detox and some pieces like that because we're harm reduction, so don't hesitate to reach out. The provider form is there, and you can see if we are able to help your folks via telehealth. Then want to note, we do have one staff member here. David's actually here today. He can provide naloxone overdose trainings and things for people that are injecting drugs. And then at Hawaii or hhhrc.org, we have a reentry page that links people that are coming back out to every resource we can think of in case they need to get help with housing or help with SNAP or help with anything else. Just want to say thank you. And 3 o'clock on the dot. Good, I talked fast. Well, thank you so much for being on the and I'm looking at the slides, but y'all have a 10-minute break until we reconvene in the large ballroom. But thank you so much, everybody, for coming to our session and for all that you do for our communities.